Good morning and welcome to the 21st NAPICU conference titled Achieving the Beyond Restriction. I trust that you would have had a reasonably pleasant journey up here. I certainly did 1.5 hours from London, so it wasn't too bad. Kiel apparently is the 6th most beautiful university campus. I can see that. Not very much when it's raining, but I can understand what they mean. It's a beautiful campus indeed. The scientific committee led by Pereira has put together a wonderful and have organized a fantastic 11-course educational gourmet meal for you, which hopefully you will absorb and enjoy over today and tomorrow. Over a period of time, we've consistently had various regulars in our educational restaurant, if you like. And to all of the regulars out there, welcome. And I see a few new faces, and you are very welcome too. We're planning to introduce a loyalty discount card in future, like Tesco's, Sainsbury's, and all the rest in future. At the very outset, I'd like to say also many thanks to Jill Moore from Northern Networking. They've run our conferences for over 15 years now, and they do a wonderful job. And I also want to say thank you to our sponsors and exhibitors who help, in fact, subsidize the delegate rate that you pay to come to our conference. We are very grateful. I'm also very grateful to my executive committee who work very, very long hours and extensively over the period of a year to put together programs like this and run a lot of the events that you probably see in the newspapers or in terms of guidance, but in reality there's a lot of work that goes on. So I'm very grateful to my executive committee for that. But most of all, I'd like to say thank you to you. You are a multidisciplinary audience. You have worked in intensive care and low-secure settings and challenging settings for a very long time. You do a very challenging job in very difficult circumstances. It's usually political, it's high risk, and it carries with it a great degree of burnout, a great degree of stress, and you have dedicated your lives and your careers to it. So I'd like you to applaud your teammates and colleagues for being in this particular specialty, looking after the most vulnerable of the severely mentally ill population. So thank you. So it was 1996 when we set up NAPICU, and the aims then and the aims now are no different, which is to advance the cause of intensive care and low-secure services for this most vulnerable and severely mentally ill patients, to try and improve and look at the mechanisms of the delivery of psychiatric intensive care, to audit the effectiveness of what it is that we do, whether it's seclusion, tranquilization, or any other intervention, to try and further promote education and practice development, and to raise awareness in the field of mental health about psychiatric intensive care. And these have been our guiding principles since 1996, when a group of us set up NAPICU, and they haven't changed since that time. And we've always endeavored to try and deliver according to each one of these aims, as you will see. So we've done this through a variety of mechanisms, not only through education in terms of books, but also trying to establish courses. And we are actively looking at an online course to establish a certificate and in due course a diploma in intensive care and low secure care. And we do this through this is the 21st National Conference, to over 80 quarterly meetings that we've run. We do various workshops in various settings, not only in this country, but abroad. But very importantly, we also, we have done in the past national surveys. The survey that I published in 2002, 3, 4, and 5 was reporting on the largest data set of patients in the world on intensive care, low secure settings, as to their demographics, their profiles, their risk profiles, and various aspects of not only their care, but also that of patients. And in the past, we used to have a practice development network. We currently have this in the form of a collaboration with the Royal College of Psychiatrists in terms of accreditation, AIMS accreditation, PQ AIMS accreditation program. And then, of course, we have the exec committee that runs, if you like, a lot of these different innovations and developments in practice. And then we have a very political role. We have to advocate for our constituency. We have to advocate for our patients in intensive care, low secure settings, because they traditionally have not had a voice. And we have been that voice advocating for them with the policy makers, with commissioners, and with our consultant colleagues and various others. And we continue to do that. So this is what the exec committee looks like. This is just for your information. And each one of these individuals have done sterling work over a very, very long period of time in running various aspects of psychiatric intensive care, low secure practice development work. And I'll probably come to some of them during the rest of my presentation. So this is a bit of the timeline for you. I was just saying, talking to Jane earlier on there, my daughter was about 3 years old in 1996. I know I'm one of those child marriage type of people. I started very young. She's now 24, and then when she was 3 years old, she said, Daddy's going off to an NAPICU meeting. And I just spoke to her yesterday, and she said, Daddy, you're going off to an NAPICU meeting? And I said, yes. So it's very much part of her childhood vocabulary, if you like. And that hasn't changed. In 1997, we published a survey, Dominic Pierre, Carol Payton, called The Hotbeds of Psychiatry, where we published this first survey where we reported on data of about 1,200 patients in intensive care, which we published in the Psychiatric Bulletin. We introduced a module on intensive care at the Mental Health Studies at Guy's Hospital in London. Then we had our textbook, the first textbook in 2001. It's the only worldwide textbook, it still is. And then we wrote the National Minimum Standards, which was a trailblazer in the sense that we never had national minimum standards, and this was published in 2002. And then we also established a course at South Bank University, which ran for a couple of years, but it was very geography-based, and we're now determined not to do geography-based courses, but to do online courses so people from all around the world can access them, because that has been the request of various individuals over a period of time. We established a practice development network with Stephen Dye and Johnston Grant in 2002. We were involved in the NICE guidance in 2005. There was a governance network I referred to. We published data on national surveys. The second edition of the book was in 2009, and we are working on, or will be working on, a third edition of the book. And then in 2014, some of you may have seen, we updated the 2002 guidance. So that becomes the definitive national minimum standards of psychiatric intensive care. If you haven't seen it, I'd be hugely disappointed, but you must see it, because that helps dictate practice in intensive care settings. And then, of course, there was further NICE guidance updating the 2005 guidance. Then last year, we published psychiatric intensive care for young people. And I don't know how many of you would have seen the national minimum standards for psychiatric intensive care for young people. And this is a very important piece of work trying to help define quality standards and minimum standards for very vulnerable young people in very difficult circumstances. This was a piece of work that was led by Matthew for us. We've also launched a new national survey. Then Faisal Sethi for us led work on new guidance for commissioners for PQs, which we'll be talking about later on today. And next year, we are going to release guidance on national minimum standards for psychiatric intensive care in high secure settings, such as Hampton, Ashworth, and Broadmoor. So we are actively working on this at the moment. So there's more that is due to come in this particular space, because all the time we want to drive quality. We want to drive national minimum standards. We want to have our patients expect a minimum level of care in this particular space. So this is just historical, really, from how bulletins and newsletters used to look like in the past, leading to this. And this piece of work is led very ably. And I don't know if you've seen this. If this is a plug, you're absolutely right. It is. You must go out and brush up and make sure that each of your institutions has this Journal of Psychiatric Intensive Care, because it's the only one of its kind in the world. And it has fantastic articles. Roland Dix has led this for us in a very able manner. His latest edition for September contains articles on the PQ, personality disorder, modification of behavioral activation as a solution to reducing patient boredom, carers matter, acceptance mindfulness within the context of psychosis and depression, OT input into psychiatric intensive care, and so on and so forth. We have various multidisciplinary articles in this. It's very highly regarded, this journal, and it goes all around the world. We've established a NAPICU publishing arm. Cambridge University Press used to publish this for us, but we've taken on the publishing ourselves. So NAPICU now has a publishing arm where we'll publish the intensive care journal. So these are the implementation guides that we have had. These were the days when pigs flew out of the department in terms of policy implementation guidance. They no longer do that, so we've taken on the task. This is the second edition of the book, and of course the 2003, 2005 conferences, and now we have the 2016 conference. In some of the earliest guidance in terms of rapid tranquilization and short-term management of disturbed violent behavior in inpatient and emergency departments, there's a piece of work that I was involved with Peter Pratt. And Faisal Sethi has been involved in the updated guidance of 2014, I think it is, 2015. And so this piece of work, so we've been involved in all these pieces of work. The other important point to make is really the accreditation program that we've established at the Royal College. This is the AIMS PQ program. We provided a lot of the intellectual property and the kind of fundamental basis for running of this AIMS PQ program. So this is an active collaboration, and that continues. The other point that I would like to make really is that over a period of time, we worked with various constituencies, not only in in England, but in Scotland and Wales and Ireland. Our next conference is going to be in Dublin. You would have the dates in your pack. And the point is that we have various intensive care clinicians in various parts of the world who reach out to us. So for example, in our membership, we have members from Canada, PQ units from Canada, from Australia, from New Zealand, from Iceland, Finland, Denmark, and various other places who actively engage with us in the whole intensive care low secure agenda. We've helped and advised governments in in 2 or 3 different countries, and people look towards the practice that we have and practice that we develop. So sometimes when we work, we feel that some of the things that we do are fairly archaic and very old, but it's quite revealing, really, that sometimes the practice that you will find is about 10 or 20 years ahead the practice of some other countries in the world, because all the time we work towards developing various dimensions and aspects of care, not only in psychopharmacology, but in also nursing care, in occupational therapy, and in psychological interventions. So I just wanted to make that point that actually, whilst you may feel demoralized sometimes and feel battered down with all the politics and everything else that goes on, in reality, you're at least about 10 or 15 years ahead from the rest of the world. And it is a point worth remembering. So this is our latest, newest, and most important venture, which is the National Survey of Intensive Care, Low, Secure, and Locked Rehabilitation Services. The National Survey, as I mentioned earlier on, we published in 2002. We reported on data of about 3,800 or 4,000 odd patients at that particular point in time. with a view towards determining not only patient characteristics, but also unit characteristics as to what were these units, what did they call themselves, were special care area, high dependency units, psychiatric intensive care units, or something else. And that original piece of work helped define the fundamental basis for psychiatric intensive care. What we now want to do is to improve on that data set which we published in the early 2000s. And we have an excellent research fellow called Lucy Walker. I'm not quite sure where she is. There she is. Who is going to be delivering on this piece of work with Informed Thinking, a research consultancy that we've engaged with. This is going to be a snapshot design. I want, please, each one of you to actively engage with this piece of work. It is a very important piece of work. We probably will land up this time collecting data on 7,000 to 8,000 people in intensive care, low secure, and locked rehabilitation settings, whatever that means. And we have the backing of various institutions to do this piece of work, because again, it will be the largest piece of work in terms of defining a patient data set in the setting. 5 minutes, thank you, plenty. We've already liaised with various institutions to have a list of 1,400 facilities that provide facilities to detain patients with service users under the Mental Health Act. What we intend to do is contact the CEO, medical director of each one of these facilities, or the nursing director. We contact each one of these units to try and determine what they are, or what do they call themselves. Is it a psychiatric intensive care unit? Is it a low secure unit? Is it a locked rehabilitation unit, or something else? And then we're going to have a census day. On the census day, this is a date to be determined, but it will be sometime, most likely in September, where we want each nurse ward manager or the consultant or the junior doctor completing data of their 10, 12, 15 odd patients that they might have on this unit. Lucy, do you want to come up here briefly? And you can I'd like to introduce to you Lucy Walker. She's a very experienced research psychologist and now currently NAPICU research fellow. So do you want to just talk through 2 or 3 of these slides?
Well, hello everyone. We've currently identified 389 units throughout the UK. But as I found out this morning through talking to some of your units are actually not on our data set list. So please do stop by and talk to me and check that your unit is on our list for this incredibly important piece of research. We've identified 125 PQs, 169 low secure, and 98 locked rehabilitation units so far. The current data set is showing that since 2001, PQs have remained fairly constant, but there's been a rise in the private sector with low secure and locked rehab provisions since the original surveys. Whilst we've seen a reduction in the proportion of the private low secures, the actual numbers has increased, which suggests that there's been a shift in the redistribution of services from the NHS to the private sector. So please, just to say, please stop by the NAPICU stand, come and talk to me, check that your unit is participating. You can have a look at the questionnaire, give us some feedback, because the questionnaire is not set in stone at the moment. So if you'd like to have a look, please do come by. I'd like to introduce you to my colleague Norman Urko, if you'd like to stand up and say hi to people. So please do come along and check that your unit's actually on our list and pick up some information, leaflet and a business card. So thank you.
So, as you've heard Lucy say, this is a very important piece of work for us, because this will help inform further developments, practice development, policy, and various other aspects of intensive care psychiatry, low secure care, challenging behavior care, and indeed defining this whole space of locked rehabilitation over the next 10 to 15 years. What we're trying to do with this survey, unlike the previous survey, is establish an electronic platform so we don't have to repeat surveys like this. I won a research grant to the tune of about £200,000 to try and deliver on this particular piece of work, but we cannot guarantee this kind of funding in the future. So we want to establish a platform where automatically we will have surveys like this that are going to be updated at regular intervals. So your participation in this will be hugely hugely appreciated. So that's really all that I have to say in taking you through a journey and introduction about what we've been doing over the last 21 years. It's been a wonderful journey. It gives rise to a great degree of satisfaction that we've been able to influence care for a group of very vulnerable patients suffering from severe mental disorder over the last 21 years. We had nothing before 1996. And now there's a whole field that has developed that defines standards, practice development, education, and we feel very proud of that. And you should too. Thank you very much.